Good.
Welcome. Thank you for coming to our 9:30 talk. I'm Vina. I'm the glaucoma marketing manager. And today we have speaking for us Dr. Giovingo, and I'll let him take it
Cool.
away.
All right. Well, welcome. Thank you all for being here. The title of the talk is MicroPulse TLT Laser Therapy: Improving Outcomes in Patient Experience. I'm from Chicago. I've been using MicroPulse and the G6 system since roughly about 2015. So I've seen several iterations. I've been part of the group consensus papers that we published that looked at recommendations and everything. And so I'm just going to hopefully give you a little bit of a few tidbits to improve your outcomes with it and try to get the best pressure lowering for your patients and also the best experience. So I know there's going to be several other talks, and I don't want to beleaguer on too much of this background stuff, but I do think it's important to note a few things. One, that it is a thermal laser. Two, thermal, whether or not we are using continuous or micropulse, the absorption does change dependent on pigment. So just like anything, like a YAG laser won't uptake without pigment. Same thing with this, and you can get some variability if we're looking at a situation where there's marking pen, blood, or blood inside the eye, et cetera, et cetera. So take caution with that. And another thing that I get a question of all the time is micropulse transcranial laser therapies, the new thing. Do you still use the G probe? And this is not a talk about G probe, but absolutely. There are some papers that promote similar outcomes between the two. I do think that they are different. They do have a little bit of a different mechanism of action, and there's some similarities in the Venn diagram, but the G probe is a much more powerful laser, still reserved for patients with lower visual potential. I think it's much more successful, though, especially in the case of neovascular glaucoma, which we'll touch on in a little bit. Just as an overview, the new Rev2 probe, which I'm assuming just about everybody is now on board with. I bet there's not many users out there that even remember the original one and some of the trials and tribulations we had with that. But much more intuitive probe. It's much smaller, thinner, easier to get into a patient that has tighter lids, tighter orbit, et cetera. The consensus paper, we were in the 80 to 100 second recommendation for treatment with 2,500 milliwatts. I've actually gone much more to the 25 or to the 120 seconds as my starting. So I've been kind of going up. Yep. And so you just kind of going up and up and up with my treatment times has significantly helped. Position at the limbus, curved edge towards the limbus, and for, again, anybody that remembers the old one, it was like which side goes to where and was kind of difficult. And then this is extremely important, and I can't tell you enough times that I have somebody that says they're getting a suboptimal outcome, that they don't really pay any attention to the treatment speed, so the sweep speed that you're using. And for the longest time, most people were in the 10-second range per sweep, and I'm talking in hemispheres. I know some people discuss quadrants, hemispheres. Everything that I'm talking about, I refer to hemispheres. And then we started going more and more towards 20 seconds based upon some work by Dr. Johnstone. And the main thing you have to think about is like a candle. If I'm flicking my finger through a candle back and forth, the slower I go, the more heat that gets delivered to my finger, the more energy. And so the slower we go, the more treatment to that tissue. 20 seconds was kind of the standard for a little while. I've actually just recently gone up to 30 seconds as my baseline. I start at 30 seconds and have been seeing better outcomes pressure-wise, haven't seen any changes as far as complications, CME, et cetera. Lid speculum, plus or minus, I like using them. Some people don't. The new probe is pretty easy to get it in there. Just a little bit of physics that, this is basically just chopping up the power back and forth. The initial thought was to direct it only to the tissue we're aiming at and not to surrounding tissue. But it does seem that maybe it does something a little more than just G probe light. The new probe, less variable treatment, easier placement. Don't need to posteriorly place it. So if anybody's used to the old one, just as a FYI, this one does go at the limbus, and better with tight exposure, which the old one was very difficult to get in some of the patients, especially if you were doing a block and everything was tight. This is Rob Noecker's publication. It just kind of tells you that there is much less necrosis of the tissue post-operatively, but there still is some. So this likely has a multifactorial mechanism of action, but there is some necrosis to the tissue. So if it isn't very destructive, what does it do? And pretty much every talk I have to include this in this. Dr. Johnstone's a good friend and just an amazing mentor and very, very smart man, much smarter than me. But he came up with some interesting post-mortem data on human eyes that were treated, and he actually showed, and let's see if the video comes up, when we place the probe, that the sclera in the area actually kind of shrinks, and that's what's partially happening. Expands ciliary bundles, and then increases outflow through the conventional pathway. And why is that important? You know, as a clinician, do you really care? I truly believe that if we use this earlier in our disease algorithm, that it does work better. Patients, you know, that have not been on chronic aqueous suppression for 25 years, they will do better. And when I always hear of, you know, well, what level of glaucoma can I use this at? Well, are we talking optic nerve? Are we, you know, if somebody was controlled on 2 drops for 25 years, well, they've been on 2 drops for 25 years. The aqueous has not been flowing through the conventional channel, just as we talk in the MIGS world of, you know, is Schlem's canal open? Are there strictures? What's going on with the collector channels? If everything's been damaged over 25 years, even though the nerve isn't very advanced, this patient may not do as well with this. I still think it's worth trying. The downside is not very large, but don't promise the world to this patient. You're going to, you know, we're going to take you off all your drops and you're going to have beautiful pressure for the rest of your life. That may not be the patient. This is just kind of an overview of some of the more recent studies. We'll get more into depth with them, but you're looking at anywhere, depending on the study, about a 30 to 50% reduction of the IOP from the preoperative pressure. And then, you know, we talked about this a little bit. Different clinicians, and I would thoroughly stress that whatever your outcomes are, understand them, and that's what you should be promising patients. Me personally, I don't really see too much of a reduction in medication. There's several studies that, you know, agree to that. I don't use it as much in patients that I have on 3 drops and are controlled, and I'm trying to get them off of medications. But I have some colleagues that do and get great outcomes with it, and that's, you know, what you have to go with in your hands. Just like any other product on the market, you have to understand what your outcomes are when you're making promises to patients and having discussions. So how do we get better? You know, you're getting okay outcomes, but I want to make things better. I want to get my patients at the lowest pressure possible. Well, more power. Sarif Pour et al. This is Dr. Ratcliffe's group, who I think is talking a little bit later today. They took patients with lower vision at the beginning of this, and they went from 2,000, 2,100, 2,250, and then 2,500 milliwatts. And what they saw leading out to a year, there was a statistically significant difference in the pressure lowering, heavily weighted towards the 2,500 milliwatt group, which that's where we've gone to with this. I know the Rev 2, I don't know, Kevin could probably tell you, but the 2nd or 3rd person in the entire world to use it. And we started off with 2,000 milliwatts, and the outcomes were pretty good, and we started working our way up. And what we're trying to find is what is the adequate balance between safety and efficacy. We don't want to go to a point where, you know, lots of patients are having CME and we get more of a G-probe-like effect. So where are we at? And right now, 2,500 milliwatts seems to be the sweet spot. It may be a little bit more power even, and that's what you have to judge as the clinician. The next thing, time, the treatment time. And again, understand your outcomes. If you are getting suboptimal outcomes, you need to be treating more. It may be some just tiny differences in what the clinician's doing. But Sanchez et al., this is Tomas Grippo's group, showed basically, you know, they went from 100 seconds of treatment to 160 seconds to 180. And again, as we increased the time of treatment, the pressure lowering was more, going all the way out to basically a year. And then the final thing, this is Grippo again, and this was the first paper that looked at fluence. So I don't need to get into the nuts and bolts of this. I even find it difficult myself working through fluence calculations. But the main point is fluence was the first calculation that had dwell time or sweep velocity involved in it. And that was the main difference between these patients. There was 2 groups, one that had a higher fluence, one that had a lower fluence. And the difference in the fluence was the dwell time, the sweep speed. This was a meta-analysis of a bunch of different studies they pulled together, lots of patients, and it really did show through that the slower we go, the lower our pressure is going to be and a sustained outcome. Then we get on to, and I absolutely love this new program. So one of the things I used to do with my residents and myself is having somebody call out the time, because how fast is 30 seconds? You know, you're in the OR, you just had a really complicated cataract, you're finally onto your lasers, you're just tired, you want to get done for the day. Well, am I going too fast? Am I going too slow? You need some uniformity. If you're going to have, make some statements to patients based upon your outcomes, the actual procedure itself needs to be uniform. And so this software basically calls out the middle of the hemisphere and then the end when you should go back the other way. I was going to have a video on this, but didn't end up working out. But there's like one bong when it hits the midway point and two bongs when you're supposed to go back the other way. And I can't tell you enough well, I was doing exactly the same thing. I just was calling it out, and that was kind of getting annoying because my residents, they do great, but you tell them 20 seconds and they've done 4 sweeps and you're only 5 seconds into the procedure. So it's absolutely crucial that you do this the same way, the same time. This is an easy procedure, and I think one of the problems that come through with it is we just look at it as this is easy, this is beneath me, I'm just going to do it real fast and get it over with. And it's attention to details in anything in glaucoma, trabs, MIGs, tubes. You have to do the same thing the same way every time, and that's how you get repeatable outcomes. So I highly recommend this software. If you're working on an old machine, talk to your rep and try to see about upgrading because it makes things much easier. Other outcomes, patient selection. As I said, early to late glaucoma, anywhere in the disease process, I personally don't use it as a medication decreasing procedure, but that doesn't mean it doesn't work in other people's hands in that way. I usually work my way up to maximize medications, and that's where my algorithm, we're starting to talk about it with patients at the point of, are we doing incisional surgery? Are we doing MIGs? Or are we just going to try to take, conservative outside of the eye approach? Can be considered any disease, any stage of optic nerve damage. Given promotes a mechanism, and this is what I keep stressing to people, well, why is it not working? Well, you do have to have some functional conventional outflow for this to really work well. And so take that into account and try to maybe use it earlier in your algorithm. And I use it as an alternative to incisional surgery. I offer to both patients, and I'm not going to make any promises that, this is going to be as great as it. It's not going to beat a trab pressure-wise. It's just not. That's not the truth, and I'm not up here to tell you that this is a magic bullet. It's another great tool in your armamentarium as a glaucoma specialist. And I basically tell the patients, it's a much better recovery. The chances of it getting you down to goal pressure is lower than a trab, and the chances of you getting off of all medications is significantly lower than a trab, but you're going to be a lot happier at about post-op week 1 than when I do a trab on you and we're doing digital pressure and bleb needlings and 5FUs and you're coming to appointments constantly. So it's just a different option, and you have to lay that out for the patients quite clearly. My mainstay, just as a plug to trabeculoplasty, is huge. If you guys haven't read the light trial, please do so. Trabeculoplasty needs to be first in your algorithm, period. I don't think that there's any question that that's like standard of care these days. And then I go on to drops and then MicroPulse versus incisional surgery. And the one spot that I do actually find it very useful is in patients that have had prior incisional surgery and have a suboptimal outcome, especially tube shunts. Somebody that I needed a pressure of, say, 15, and I'm hovering on around the 19 to 20 range. It works quite well in those patients. And this is a big one. It does not work great in neovascular glaucoma, again, because of that point of the conventional outflow pathway is just destroyed in those patients, and that's why I tend to more go towards a G probe. It can be used, though, in a situation where I need to lower the pressure temporarily. I think it was an acute enough attack that I just need to get my neovascularization away, and it'll lower them for a little while, but that effect will tend to be limited, and that whole concept is supported by multiple studies. So probe angle coupling agent, this is just a personal plug. This is something we published before the Rev 2, just saying that the actual angle, which now is not an issue because of the much better coupling mechanism on the Rev 2. But the other thing is we found that in a dry situation, the power of the laser is significantly lost. So, and I think I have a video coming up, but we didn't find any difference in any type of coupling agent, whether that was just a gel, a lidocaine gel that happens to be in the OR, or tears, tetracaine, et cetera, et cetera. This is just kind of a quick little video of a patient that we did just so you can kind of see. I like using the speculum just for exposure. It's nice. You can see this patient's had a trab, but it's quite flat. As we start, I just load up the eye with lidocaine gel. I just put it all over it, just goop the whole thing up. We had it there from the cataracts. Make sure that I am getting delivery to the tissue. And again, it's just doing the same thing every time so I can know where my outcomes are at. And then we go ahead and treat. There's, this isn't too much of a lecture on how to do this more, but I do think that some type of coupling agent is absolutely crucial. Anesthesia, I think more and more clinicians have gone towards operating room setting. I still kind of flip-flop between the two. I'd say probably 2/3 operating room, 1/3 minor room with a block. There are a lot of different opinions about this. I'll just give you mine and what works for me. Doesn't necessarily mean that this is, absolutely the way to go with it. In the operating room, I do no block, no injection of any sort. Anesthesia, we've come to a really good agreement where they understand that it's a 2-minute procedure. I'm not the surgeon who's lying and say I got 20 minutes left and 4 hours later we're still going. So they understand that, and they understand they just give a little bit of propofol and some benzos, and the patient goes down just like an induction block, and they come right back up and they do well. And the other question is, what about post-operative pain without a block? They do extremely well. Rarely do we have a patient who has any significant pain issues afterwards. And then, in the situation of I need to repeat it down the road, the patients that have this no memory, completely happy experience, they say, okay, Dr. Giovingo told me, a few years down the road I might need a touch-up of this, and okay, now's that time, no big deal. Occasionally you have a patient who's not healthy enough to go to the operating room, or every once in a while I'll just have a patient just wants to get it done. They don't want to deal with any of it. And I'll do them in the minor room setting, whether that's a G-probe or a MicroPulse, with great outcomes too. My recommendation to that, and I know there's different people saying, some people do subcons, some people do peris. I do a retro bulbar on everyone. I make them extremely comfortable because, again, nothing is a forever procedure. Glaucoma, we're planning for the next step every single time. Even with trabs, why do I do a trab nasally? Because I'm assuming it's going to fail and I'm going to do a tube somewhere down the road, and I don't want to mess myself up on the next step. I don't want my patient to have an awful experience with this when 2 or 3 years down the road I say you're going to need another treatment. So I want them to walk out happy. Now with the block, they have to do a patch, and that's kind of terrible, especially when I have a monocular patient and that sort of thing. But that's where you kind of weigh each patient. You have a conversation with them, and you tell them what they can expect. But I do think anesthesia is an extremely important one. More and more clinicians, I think, are going towards the operating room setting too. Post-operative, I've gotten completely away from using atropine. We did in the initial stages of this. I don't think it's necessary at all, and patients hate it. Prednisolone, I've gone from a full month of treatment to now I don't even want them on it on the post-op week 1 when I see them. I do 3-3-2-2-1-1. I get them off of it fast, and rarely do I see any significant cell on post-op week 1 completely off of it. Plus, I want them. I don't want any pressure spikes. I don't want to deal with. I just want a quick little taper. But there's some people that do it completely with no pred. I haven't gotten there yet. I don't want phone calls left and right. And then the IOP drops, I continue them right away, immediately afterwards, regardless of the pressure, and then I taper as I see fit, because your day 1, week 1, even your month 1 pressure may not predict exactly what you're going to see. It's usually the month 3, month 6 that you start to see what you're really going to get out of it. So a couple of cases. We doing okay on time? We good? Ish? I got 3 cases, but we can yell at me if we want to cut it. So, okay. 63-year-old Nigerian woman with combined mechanism glaucoma, well known to our service, underwent LPI 5 years ago. Reasonably good visual acuity, pressure in the right eye is 24. She's only on 2 medications, but has an issue with severe asthma, had a bromonidine allergy, so essentially in her case we're maximized. AC depths moderate, LPI 2 to 3 plus NS, but again the vision's not too bad. The right eye definitely has some more thinning than the left, as we can see in the visual field. Early nasal step, and this is where I'm talking about, depending on the disease process, I can use this in early nerve damage. I can use it in later nerve damage. You just have to kind of weigh what you're looking for, what your goal pressures are, and what the patient's expectations are. So, the right eye at 24 is definitely above goal. We discussed getting her off of medications altogether. She doesn't really like them, but then she also didn't like the prospect of trab. She didn't like the prospect, which, again, and I'm talking for Iridex at the moment, but in this patient, somebody who's chronic angle closure, even just a phaco by itself or a phaco plus a MIGS is not a bad option, but she just adamantly wanted nothing. So what do I do with this patient? If I have no surgery on the table, she's above goal, I'm just going to watch her getting worse. She went through a MicroPulse in the OR. This was back, we were doing 60 seconds per hemisphere. I'm going way above that now, but she did pretty well, and the sweep speed was 20. So this is kind of a lower treatment for what I do currently. Very little inflammation, got off the steroids, pressure all the way down to 15, current meds, all the way out to month 7. Humphrey visual field remained stable. She did great. Now, whether or not that lasts 2, 3, 4, or 5 years, some patients do. Some patients, a year or two, we need to do a touch-up. And the more we know now, I definitely would treat her a little more aggressively if we end up going to a second round of it. Case 2. This is going to be a bit of a different case, and I apologize. I thought it looked a little bit bigger, but that's on my laptop close up. 61-year-old African-American female, end-stage open-angle glaucoma. Now this patient's 0.99 cup, thin corneas, had a trab in the 90s, had a MicroPulse a year and a half ago with the original probe, status post-express shunt 10 years ago, so we've had a whole lot go on. 2400 vision, flat bleb, side-L negative iris plugging. The other eye has a flat bleb as well with an express shunt. She's on pretty much maximum for her. Can't tolerate Diamox, but even in the case if she's truly taking the dorzolamide, the Diamox shouldn't do much. This is her field, not looking great. OCT extremely thin. There's definitely some myopia with some angled nerves, but there's a lot of thinning going on here. And in these cases, I do kind of push more towards the incisional, but again, patient's not having it. And that's one of the biggest problems I've had in the years, where you have a patient and you need surgery, and they say no. You're not doing it to me. This woman had multiple surgeries. They all failed. They ask you, what's so special about this next surgery that it's going to work? That was terrible. At least I have something to offer them. I'm not saying that 100% of patients are going to go down to 10 for the rest of their lives with this, but it is something to offer, and it will buy you some more time. And if it fails in a year or two, we could repeat it a third time. It starts to get a little bit questionable. How many times can we repeat it and whatnot? But depending on the outcome, if I get a few years, she could have a third one. And a little bit higher treatment this time, 160 total. 20-second sweep speed. I do recommend the 30, actually. I do think it does a lot better. And then, she went all the way out to post-op month 5, still on her medications, but a pressure of 11. She's doing great. And again, we'll see how she goes down the road. And because she had anesthesia, if she needs a third one, she's not going to be very upset with me about, when it does fail. And the final case, another challenging one. This one is fun. 56-year-old male with end-stage open-angle glaucoma, as tends to happen in my clinic. Monocular, right eye is only 20/60. History of trabeculectomy, 1998, so could be a problem there. IOP was 9 and 12, so what's the problem? Well, avascular bleb, cystic, over the years following surgery, advanced nerves. Well, patient started becoming hypotenuse. We had a bleb leak. We tried a few different more conservative things to do, especially on a monocular patient with this advanced field. Autologous blood, gentamicin, doxycycline, bleb suturing in the minor room, which actually made it significantly worse. And so I ended up having to take him back for a full bleb revision, which I really, really did not want to do. This made things extremely difficult. Side-L negative post the revision, but now our pressure shoots up, which is, kind of the yo-yo effect of glaucoma. And for the glaucoma specialists out there, you saw this one coming. It's like, oh, great. We had a great pressure, but we were leaking. Did everything I could, sutural lysis, digital pressure, bleb needling, medications added. So now what are we? We're at 23 maximized again after this. He's not leaking, but we got a problem. This monocular patient with 20/60 vision is going to go blind. Talked with him about MicroPulse. 100 seconds to treatment per hemisphere, 200 seconds total, 2,500 milliwatts power, 20 seconds per sweep, and the guy did great. Even went over the trabeculectomy site. That's another question I constantly get. Can I go over trabeculectomies? Can I go over tubes? I haven't had any issues with it. If the tube is or if the bleb is elevated, don't go over it. Obviously, they treat different areas. But these flat, destroyed blebs that are not doing anything, go ahead and go over it. I need more treatment area. I want the best pressure that I can get. And he did all the way out to 3 months. We'll see how he ends up going. Pressure of 11. And again, as I've kind of pointed out multiple times, I don't tend to get too many medications off. I do occasionally, but it's about patient expectations. If I sit there and say, oh, this is going to be great, you're going to get off of all your medications, and then they're on all their medications, the patient's mad at me. If I tell them you're not going to get off of medications, and then they do get medications taken off, I'm a hero. So it's all about how you present it. But overall, he did well, and hopefully I don't end up having to put a tube in him down the road, but I always still have a second MicroPulse in my back pocket. Oh yeah, feel reasonably stable. He did have some pressure spikes in it. There we go. Thank you. That's Maui, right by, unfortunately, Lahaina. Beautiful place. So, any questions? Go ahead. Oh, yeah. Thought it'd be easier.
Thank you for that.
Yeah.
The take-home. Test. Okay.
You're
So,
on. Gotcha.
Thank you for this. And
Yeah.
the take-home for me really is to slow down the sweep speed.
Yep.
I've been doing a bunch of these. Pleased with my results, but certainly looking to improve
Yeah.
my results. And everything that you've shared with here, I think you're like my brother from another mother. I think I'm doing
Love
the
it.
same thing.
Yep.
Same thing you're doing, talking to patients the same way,
Yeah.
and encountering the same kind of patients. I guess what maybe concerns me about slowing down the sweep speed, and what I do is I put some Act10 gel on the probe.
Mm-hmm.
I'm doing quadrants, 50 seconds per quadrant.
Okay.
As I've slowed down, I've noticed that I have had some conjunctival burns. And seeing these
Interesting.
burn marks, and they're little focal things. It's not like a whole track or anything, even though I'm sweeping at the same velocity, but they'll just be these little focal burns. And we've had our laser calibrated, checked on everything. Everything seems to be checking okay. But that's been something that's been made me a little reluctant to slow down, is seeing some of these conjunctival. Now, they're gone by the 1 week. I'm like you, I see them at 1 week. I don't see them the next day. I see them 1 week. They're gone, and they're fine. Their conj is white and quiet.
Yeah.
But these burn marks concern me some.
That's
that I've been
interesting.
seeing.
That I have it. It kind of harkens back to the old G probe. I remember the ones that were reusable. You'd kind of take it off, and when my resident didn't clean it, and there was particulate matter, I used to see, and those burns were terrible. Actually, they never went away, and patients were uncomfortable, and it was terrible. I haven't seen it with the MicroPulse, but again, everybody's experience is a little bit different. My main question back, though, would be, are you seeing heme when that happens? No. No heme.
There's maybe some melon in
there. What is your patient population? Primarily Caucasian?
It's mixed.
Okay.
I would say in the few cases I've seen, that probably has been more person with pigmented ancestry.
Huh. Interesting. No, it's all about, again, your experience versus my experience. I can tell you what works for me, but when something, if you try slowing down and you're starting to have problems, back off. And that was the main thing with the consensus, that this is the consensus recommendation. If it's not working, and I always I like moving one thing at a time. That you have your 3 parameters. You have time, you have power, and you have dwell speed. Don't move 2. Because then you don't know what fixed the problem or made it worse.
So you're putting that viscoelastic all over.
I just douse it in there.
Do you reapply more when you go for the?
That's why I kind of just douse it, and what I'll do.
So that's the one time only, good for the.
Well, if on the when we move to the inferior, if it looks dry, I literally have it sitting on the patient's chest just right here as we're going, and if I go, just throw some more, and at the midway point, I can't stress enough, I think, and that might be some of it too. But it also, the delivery, you think of something going through air versus going through a fluid, that power is going to travel better into the tissue we're arguing. Yeah.
Yeah. It's usually 5, so like 10 seconds.
Right. Which for me would be at 20 seconds if he's doing quadrants. So essentially, it's similar to what I'm doing. It's just the way that I was doing it like 3 or 6 months ago. But no, it's interesting. I would certainly try the lidocaine. If it works great, and it just kind of sits there for forever. The patients by the end of it are like whole face covered in it, but I don't think they care as long as they get a good pressure. So, cool. Yeah, no problem.
We have a gentleman with a question who has heard of Dr. Cyril Duraj and his recent studies on dose escalation. He was curious about what parameters you use, sweep, power.
So my go-to recently has been a little bit on the more aggressive side. I do 2,500 milliwatts, 30-second sweeps per hemisphere, and I do 4. So I do 120 seconds on the top, 120 seconds on the bottom. And I've been, knock on wood, getting great results pressure-wise. And the big thing you worry about is if we keep escalating this, at what point in time are we going to get an unacceptable rate of CME? I mean, CME does happen occasionally, especially in a patient, with baseline diabetic retinopathy. But when do we get to an unacceptable rate? And I'm not there yet. I'm not seeing patients drop much in vision at all. And occasionally it happens. I'm not going to lie and say I never get CME with patients or DME. But usually it's self-limited. So that's where I'm at. So 2,500, 30-second sweeps, 120 seconds per hemisphere. Cool.
Okay, any other questions?
So you moved to the new sweep management software?
Well, one of the places we did, and the other one I'm like begging, I'm like, can we please upgrade this one? Because I can't stand that old software. I can't even go up to 120 seconds on it either. So I got to do 90, and then I got to do an extra 30, which is like, we'll talk.
So question is, have you noticed a difference, or is it too soon to notice a difference in your patients results-wise by going to the sweep management software? Instead of having somebody call out 20 seconds, 25 seconds, are you
pressure
kind of telling you where you at? Has it kind of slowed you down even more, and you're seeing a better result?
I was always, as I said, Dr. Johnstone's a great friend, and we were chatting about this even pre-pandemic at meetings and the dwell speed and everything. So I was always a big stickler on the dwell speed, which I think is part of the reason I've been happy with my outcomes. So I don't think my residents can tell you straight too, or I'm like yelling, too fast, that's ridiculous. I said 20 seconds, it's 15 seconds and you're already at the 3 o'clock position. So I was always very big on it. So I don't think it really changed anything for me per se. And I also just made the switch from 20 second sweeps to 30-second sweeps. So it's kind of hard, too many moving parts in the whole thing. But it's just easier. It's so much nicer to just sit there and not have to worry about all of a sudden the anesthesiologist is barking about something and, the patient's getting a little too Brady or whatever. I can just listen for that boing noise and that's it. And I don't have to, it makes the procedure just easier for me, less stress and, so. But I would say for the average clinic, and it's one of the big things I see with people. They say they're doing 20-second sweep speed, and then you watch them. Or even I've seen people give talks, and they're like, 20-second sweep speed. They're like moving as fast. I'm like, that's not 20 seconds.
Well, to your point, you have the timer set at 30 seconds, and they're already, whether it be a quadrant or a hemisphere, and they're 3/4 of the way done, and they still have another 15 seconds to go. So it's like everybody's 30 seconds is a different time.
Exactly. That's the problem. We need uniformity for uniform outcomes. Plain and simple, and I think this is a great tool to help with that, and I absolutely love it. We've got to make it a little louder, though. I told you guys that. Cool. Anybody else?
Hello. Okay. All right.
Cool.
Thank you.
Thank you, guys. I appreciate it. Appreciate it as always. I'll stick around if anybody has any other questions. I'm not going anywhere.